Hi, welcome to the finale of our Facebook Live series for AFib Awareness Month in September. Thanks for joining us. I'm Callie Parker, your host, and I am privileged to be here with Dr. Brett Gidney, a cardiac electrophysiologist. Today, we have a really special program for you. We are here inside a cath lab, and we're going to be looking at all of the different items that are used during the procedure, the equipment, what staff is involved, and we're also going to be reviewing some treatment options as well, and really exploring what it does to have a cardiac ablation. So let's get started. Dr. Gidney, do you want to tell us a little bit about yourself?
Sure. Well, first of all, I'm really excited to be here. I'm really excited to have lots of guests along with me virtually in the EP lab. It's a rare opportunity, and I'm excited to show you guys what we do in the lab and how we go about doing it. I'd like to also start out by thanking Marion Regional Medical Center, where we're standing right now, and the Sue J. Sword Heart Center. The Sue Sword Heart Center is an amazing place, and we have a beautiful electrophysiology lab here. And one of the things that makes our lab unique is we have these beautiful wood-like floors and nice paint colors and beautiful pictures on the way in. So it makes it a really pleasant experience from start to finish. But to answer your question, I'm a cardiac electrophysiologist. Most of you who have tuned in probably already have a basic idea of what that is. But I'm a heart rhythm specialist, which means that I started out like all doctors in medical school, and then I did my internal medicine residency. From there, I did my cardiology fellowship. So that's 3 years of medical residency, then 3 years of cardiology fellowship. And then I did a year, although some programs are 2 years, a year of clinical cardiac electrophysiology. And that's virtually all I do. So some cardiologists specialize in both general cardiology and their subspecialty, like interventional cardiology. Those guys are the plumbers that open up arteries, or electricians like me that specialize in electrical disorders. And that's all I do all day, every day. Seems like 7 out of 7 days a week, but definitely 5 out of 7 days a week. I do cardiac electrophysiology, and the vast majority of that time is spent taking care of patients with atrial fibrillation.
Yes, you are very dedicated to your patients, and I know they appreciate it. And what a unique opportunity to be here with you today and have all the patients that are sitting out there live be able to experience what it means to have an ablation, what products are used. So what we're going to do now, if you could take us through the type of equipment that's used during the procedure and what is the purpose for each one of those items.
Okay, I can do that. So what I'm going to do now, hopefully you guys can come along with me. I'm going to point out some of the equipment that we use. So over here, we have the three-dimensional mapping system, and we'll get into some more detail about what the 3D mapping system is. But it's a large piece of hardware down here, and there's lots of hardware over there that we'll get to in a moment. And there's a couple of screens here that I can't see, but we have a big screen over there that I can see everything on. And even though I don't move over there to the other side of these screens during the procedure, I need to see what's going on, so we have a representation of them over there. So behind the 3D mapping system, we have Phil. He's our clinical account specialist, and he runs the 3D mapping system. And he and I are a closely knit team. We spend virtually every day in the lab together, or whoever's running that system on that day. It's almost always Phil for me, which is great. It helps us work together efficiently and make sure we get the job done and get it done right. And I communicate a lot with Phil. I have to tell him how to move the map, I have to make sure he's showing me what I need to see. And half the time, he knows what I'm thinking before I do it, so that's really important and really helpful. Then over here, the other item that you can't see that's facing the other way, but as important, is the recording system. So that shows me what the electrical signals are in the heart and what's happening at any given moment throughout the heart electrically. So I'm going to swing you over to where the action is now, more on these screens, and this is what's behind those other ones. So this is the recording system, and the recording system right now is showing me what all 12 leads. We talked about an EKG and a 12-lead EKG. So right now, this is all 12 leads of an EKG. And then during the procedure, this will actually come to represent all the internal electrical signals of the heart and what's going on with those. So actually, Phil just clicked the button. So now this is showing, without actually showing the actual electrical signals because there's not a patient on the table, we're actually seeing what each one of the catheters would show. And each one of those catheters represented by different colors in a different part of the heart. So then I know what's happening electrically in each of the different parts of the heart at any given time. And then I can freeze it and update, and then it'll go onto the review screen here. So I can analyze those and determine what the rhythm problem is. And we can actually do one other really important thing with the recording system. And down there, there's an amplifier, but also a stimulator. And that allows us to emit an electrical impulse from any one of the metal electrodes on the catheters in the heart, so I can actually pace the heart and make the heart go at whatever rate we need to make things happen, to make an abnormal rhythm happen, to find where an abnormal rhythm is coming from, to speed up the heart if we need to. So all the testing that we do electrically in the heart is facilitated by emitting electrical impulses from that stimulator that's sitting down under the table over there.
So if I hear you correctly, some of the signals that are shown up here, some of them are being emitted from inside the heart, and then some of them are coming from an external source?
That's a great question.
Okay.
So that's right. So when we do an EKG in our office or in any physician's office, we're looking at what's happening electrically inside the heart, but doing it from the outside. So we don't actually have anything inside the heart, obviously, at that time. But during the EP procedure, what makes an electrophysiology procedure so unique is I don't need that sort of mile-high view of what's happening in the heart. I actually have catheters inside the heart, all over the heart in different areas. So I know in a very precise fashion what's happening at any given moment from within the heart. And that makes it much more accurate than an EKG and allows me to diagnose different rhythm problems that I get a ballpark idea from with an EKG, but a lot of using an EKG is educated guesswork and learning patterns, and we don't really need to make those sorts of guesses when we've got catheters inside of the heart.
That's great.
So some of the other equipment we've got here, we have an ultrasound machine here, and just like we get ultrasounds of babies or we get echocardiograms and ultrasounds of the heart, we actually can do something really special with this ultrasound. It gives us an ultrasound from within the heart. So just like an EKG is an electrical picture from outside of the body, an ultrasound is the same thing from outside. We have a catheter that allows us to do ultrasound from within the heart, and I can move that catheter anywhere I want inside of the heart and get a better view of it up close and personal, so I can make a better diagnosis, but I can also follow my catheters inside of the heart, and that, along with the 3D mapping system, allows us to do something really unique in today's era, which is to minimize the use of fluoroscopy. Because this room that we're in was really built around the idea of being a room that allows us to use video X-ray or fluoroscopy. And video X-ray or fluoroscopy is the tried and true, long-standing method of seeing inside of the body, like with a CAT scan. But that unfortunately comes along with the problem of exposing us all, both the operator and the patient, to radiation. And we can minimize the use of that to nearly nothing by using all of these electronics that we've got here. And ultrasound is a big part of that. And I'm going to show you the ultrasound catheter in a moment, but we'll just get through the rest of the equipment first. So we'll move on. And I would say this is the featured piece of equipment because it's really what enables us to do afib ablation in the modern era. And one of the most important pieces of equipment for me to learn, and there's a lot to it. There's a lot going on inside of this system. So the brains of this system are in this, which is the PIU, or patient interface unit. And these two screens represent the heart. So this is someone's left atrium who had an afib ablation. And this shows us what's happening in the heart at any given time. And Phil can rotate that for us. So Phil, can you rotate to the right? So as Phil rotates, I get an idea of what the catheters look like in the heart. So here we can actually see a couple of different catheters represented. So if this were live in a patient, we would actually see this moving, and the catheters moving up and down with respiration, with me manipulating the catheters. I would see them move around inside of the heart. So there's a catheter here inside the coronary sinus. That's a large vein that wraps underneath behind the heart and around the side, where we like to park catheters because it's right in between the atrium and the ventricle. So Phil, rotate down for a second. So this is the mitral valve. So down here off the page would be where the ventricle is, the lower chamber. So this catheter sits right between the upper and lower chambers. So I can see electrically what's happening in both chambers at any given time from this one spot. But some more interesting catheters are the mapping catheters. So rotate left, Phil. Let's look through where the left atrial appendage would be, or through the mitral valve. There you go. So we're looking up through someone's mitral valve here. We've cut that out to represent it. And here we're actually seeing what's called the pentarae. And the pentarae is like a little squid. It's got these soft splines on it, and they move around inside of the heart and allow me to see what's happening electrically wherever you see the little gray bands. There's actually a metal band on the real catheter there, and it's recording the electrical system at that spot the entire time. And then it records what that electrical signal looked like, so when it happened and how big it was, and it color codes it on the map for us. So we know, we don't have to remember what the electrical signal looked like in each area. We actually have color coding to represent it. So here, these are the pulmonary veins, the culprits of most patients' atrial fibrillation. And in these left-sided pulmonary veins, as I went further out into them, you can actually see that the heart sleeve, the myocardial sleeve that's emitting the electrical impulse and allowing the electrical impulse to move, changes from the magenta color to red, because then it's just vein. And it's that area in here where AFib typically comes from. So it's all represented on the 3D mapping system. And I couldn't do my job without a nice three-dimensional map. And we're able to make that map by moving that catheter around inside of the heart, and everywhere the catheter goes, it creates a shell, and that shell eventually turns into this. And we do that in real time. So if we get a CAT scan of a patient a week beforehand, their heart may have changed in the interim because they were not fasting perhaps, or they had a lot of fluid the day before, so their heart might be a little larger. And then the day of the procedure, I need to know exactly what their heart looks like on that day in that position, so I can make this a real-time three-dimensional map to know what that patient's heart looks like, both electrically with those color codes, as well as structurally with the overall shell.
So it sounds like just like a GPS system in a way.
It is. I think that's a great way to describe it. That's usually what I talk to my patients about, usually compared to GPS. So inside of each of those catheters, there's a sensor, and then there's a magnet underneath the table here. And the magnet is actually talking to the catheters, and it's able to tell us where that catheter is in relation to the patient, because the patient has patches on. So it's kind of like triangulating the position of that catheter based on the fixed electrodes or fixed patches on the patient. GPS is a good way to think about it, though.
So tell me about this, though. If I'm a patient on the table, am I feeling these catheters that you have shown there?
So
Can I feel that going on?
So if a patient's wide awake, which they aren't in the vast majority of the procedures that we do, but if a patient were wide awake, they typically wouldn't feel the catheters moving around. But as the catheters move around, sometimes they cause extra heartbeats. They irritate the part of the heart that they're touching, and patients sometimes will feel those as palpitations. They'll feel extra beats, and they may notice a skipped beat. But the beauty of these procedures, and something that's changed in the majority of the United States and probably across the world, is the use of anesthesia. We used to do these procedures with conscious sedation, where patients were aware a little bit of what's happening and they've been given some sedation, and angiograms are typically still done that way. But for these procedures that are a little bit longer, we've really developed great relationships with anesthesia, and patients fall asleep before we start, and then everything's done while they're sleeping. When they wake up, usually all the catheters are already out, and there's generally little, if any, awareness that a procedure was done afterwards. There's no stitches, there's no scalpel. It's all done minimally invasively, and the catheters in the heart aren't something that someone would feel.
Great.
But general anesthesia is really important because, as I said, the system knows where these catheters are based on those patch locations on the patient. So if a patient so much as hiccups, even if the patient wasn't uncomfortable, they felt fine during the procedure, but they had to wiggle a little bit, everything would get thrown off. So we actually have really nice studies showing us that outcomes are better for these procedures with general anesthesia not only because patients are happier, but because they're able to stay perfectly still during the procedure, and the map then is accurate. So then I think the final piece of equipment that we need to know about is the one therapeutic piece of equipment that we actually haven't touched on. Everything else we've talked about is really diagnostic. It's not actually delivering anything other than the pacemaker part of things, where I talked about the stimulator earlier. But the truly therapeutic part of the procedure, where actually fixing someone's atrial fibrillation, comes from here. This tiny piece of equipment down here, it's really heavy, even though it's small, is the generator. And the radio frequency generator is what allows us to emit radio frequency current through the tip of the catheter and heat up the part of the heart that we're interested in no longer conducting electrical impulses, so that we can fix the problem and apply radio frequency ablation. And this generator does it in a really unique fashion, in that it does it by first cooling the tip of the catheter. So right next to it, its little buddy here, is what we call the thermocool system, or SmartAblate. And SmartAblate allows us to push fluids through the tip of the catheter so that the tip of the catheter stays cool, and the energy that we want to deliver goes into the area that we want to burn, rather than heating up the tip of the catheter. So that's been really critical in reducing complications and making sure that we get effective lesions. And when we say lesions, what we mean is the areas that we burned. So I think that more or less covers top to bottom. There's a defibrillator in the corner over there for in case we need to shock someone out of an abnormal or life-threatening rhythm, and we always have that available to us. There's an anesthesia cart that's a little bit out of the picture that the anesthesiologist sits in behind to run the anesthesia throughout the case. But I think that covers most of the equipment.
Yeah, and do you mind showing us just a few of the tools that you use during the procedure, maybe a catheter or two? Because I get the idea, but they look rather small.
Sure.
That's a good thing.
Yeah, that's a good thing. Yeah, small catheters are better. And yeah, let's go through that. So in terms of equipment or procedural steps, I guess, the first thing we do is we put a glorified IV that we call a sheath into a vein. And it happens to be an 8 French sheath, so we refer to sheaths in terms of sizes. And this sheath has a dilator in it right now, but that doesn't stay in. So I'll take the dilator out. So this is what a sheath looks like. It's kind of like a drinking straw, but on this end there's a valve, and that makes it so blood can't get out of it. So what I do to get this into the vein, we call it a modified Seldinger technique, but it's a really simple process. We take a needle and we put a needle into the vein, and then we take this wire and we thread the wire.
And the vein is in the leg?
In the groin.
In the groin, okay.
In the groin.
Okay.
So the femoral vein is usually where we put these. So the wire would be sitting in the vein, and then once that wire is in the vein, it gives me a track to put the sheath over. So the most important procedural step is getting access to the vein so we can put everything in. And then we thread this right over that wire, and it goes into the vein, and the wire would be sitting out. Then we take that dilator out, and we're set. So now we have, without having to see any blood, oftentimes at this point you haven't seen really any blood at all. It's really simple. No incision was made, all done with one little needle. And this now sits inside of that vein. Now through this sheath, I can put catheters in and out at will, and I don't have to worry about repeatedly getting access. So once we've done that, we want to put our catheter up into the left atrium. So the way we do that is called a transeptal puncture. And this, I think, for a time was one of the most feared parts of the procedure. It was really difficult to do. Only certain people knew how to do it. It was a complex part of the procedure. But with all the imaging equipment we have now, I think it's one of the simplest steps. And oftentimes, from the time we put this initial sheath in until the transeptals are done is under 5 minutes. So it's a very quick and simple part of the procedure in the vast majority of circumstances. And a transeptal puncture is, we'll go back to the mapping system. I think that'll help, and then I'll show you what I do. So Phil, will you rotate over to the right? So if you can imagine here on this screen, we have the right atrium off the screen here. So all these catheters would go up into the right atrium. Anatomically, that's where they start out. but I need to go from the right atrium that's off the screen into the left atrium. So the way I do it is over a long wire, I take a long sheath like this, and it goes up inside, and it touches where the thin part of the wall between the two chambers are. And once it touches that thin wall, I can actually use a little needle, and only a tiny bit of the needle goes out. So I call it a little needle, but it's actually huge. The needle goes all the way out the bottom of the leg here, so it's sticking out of this whole long thing. But even though it's a giant needle, only a little bit of the needle goes out. So I push this up against here, I thread the needle up this, and it pushes across and pops into there. And then I leave this, let's see, I'm gonna take that dilator out, and I leave this the whole time inside the left atrium. And for the rest of the procedure, this sits inside the left atrium and allows me to get catheters in and out of the left atrium without having to go back and forth from right side to left side.
So even though this looks so long, that's because you're coming from the groin area, and you're saying just this section is actually in the heart area.
That's right.
Okay.
That's right. The rest of this is, well, a lot of this is actually out on the patient's thigh area, more or less. So procedural stepwise, now we have this transeptal sheath sitting in someone's left atrium. And this is a really cool sheath. I get really excited about toys that make a big difference in making people's lives better and making it easier to do the procedure. So this is a special sheath. So it's called a Visigo sheath. And the Visigo sheath is special because before this sheath existed, I was never able to tell where this was on the three-dimensional mapping system. So I wouldn't know whether it was curled up like that or straight. And I can do that all from this dial down where my hand goes. But there was no way to really know how curled it was or which direction it was moving in all three dimensions. But this sheath, which has only recently been available in the United States, actually allows me to see it on the 3D mapping system. So when this is in the heart, I can actually see where it is inside of the heart and know where my ablation catheter is in relation to it. So that brings me to the ablation catheter. So the next thing we do is once this is in the left atrium, where we're going to do our afib ablation, we're going to take an ablation catheter. So let's see. So here's an ablation catheter, and we're going to put it in. But let's
So it's quite small at the tip. Okay. Wow, it looks like a lot of mechanics at the end of the tip.
Yeah, there's a lot of electronics. It's amazing. It's always amazing how much in the way of electronics are built into this catheter. So the tip of it the very, very tip of it is 3.5 millimeters long, and it's porous. So it used to be that there were 6 little holes where fluid would come out. There's so many little holes in it now that you can't even see them unless you get really, really close. But when fluid comes out, it comes out all 56 of those holes. So many holes that it's not even worth calling 56. It's just porous. All that fluid cools the catheter really efficiently. There's a sensor built into it, so we see where it is on the 3D mapping system. And here, Phil can show us what the ablation catheter looks like. We can look up through the mitral valve again.
Oh, okay, so, right here?
Exactly.
Oh, okay.
And there's a couple of unique things. There's a lot of unique things that make this catheter special. One is, I always know which direction it's going to go in when I use the thumb switch. So if I move the thumb switch, you can see the tip of the catheter curls. And when I pull the thumb switch back, it straightens. So this catheter is standardized so that wherever the red is on the catheter, so you can actually see a little bit of red there. It's red, then green, then blue. So there we can see red. So wherever the red is the direction that it's going to deflect. So I know before I use my thumb on this switch where that catheter is going to go. So based on where it is now, I know that if I use my thumb on that catheter, and this isn't even in a patient, this is after the fact, I already know that it's going to go that way. So it's really important to be able to see that, and the 3D mapping system and the calibration of the sensor allow that to happen. But then there's even more electronics, which makes it incredible. So one of the other things that's built in is there's a tiny little spring in there. And that tiny little spring allows us to see the force that the catheter is being applied with. So on this display here where it says NA, and there's a little G for grams there, that tells me whether or not the catheter is touching the wall of the heart based on how much that spring moves. So just like that big sensor under the table tells me where the catheter is, there's actually a miniaturized version of that entire system tracking how much force is on the spring, which is mind-boggling, thanks to the engineers that figured all this out over at Biosense Webster. So as that spring gets force applied to it, it bends. And not only does it bend and we know how much force is being applied, but which direction the force is being applied. So I know whether there's a little arrow that would show up, and I know where that force is being applied. And the reason that's important, if you're not doing this every day, you wouldn't know why that's important. But it turns out there's so many bends on the way up that I can't tell by feel whether the catheter is touching or floating. And that's a problem, because if I'm just floating freely and I think I'm touching and I say, okay, let's burn here, let's come on radio frequency ablation here, and I'm ready to start burning, if I'm not touching anything, I'm not doing anything. And there probably were times before this technology existed that we were either barely touching, so nothing was really happening, or not touching anything.
And you mean touching the inside of the heart wall?
Touching the inside of the heart
and
wall.
you're saying that's important. Why?
Well, the part of the heart that conducts electricity is the lining of the heart, the endocardial border, we call it. So the blood that's in the heart doesn't conduct the electrical impulses. The electrical impulses spread from cell to cell to cell along the wall of the heart. Mm-hmm. And that's what we want to impact when we do an ablation. So the ablation catheter will actually need to touch the wall of the heart when it emits the radio frequency energy so that we can do an ablation. So if it's not touching it, that energy won't generate enough heat to cause a problem. It'll just spread out globally without making contact with tissue. And the way to think about this is when you look at a light bulb that's not on, there's that little thin filament. When you flip the switch, it glows as all that energy goes through that thin filament. Okay. So it's kind of the same way that the ablation catheter works. When it's touching, all that energy comes out the tip of the catheter where it's making contact, and it, by resistance, creates heat, the same as the filament in the light bulb. But just like the wire on the other end of that light bulb filament doesn't get hot, the tissue just millimeters away doesn't get hot because we've got this usually on the patient's thigh. So all the energy that's coming out the tip of the catheter where it's making contact in just a millimeter, it'll actually widen out and spread out, and then eventually it gets kind of collected where this is on the leg, the indifferent electrode. So the energy, there's no heat here because it's spread out along this entire electrode. If this electrode were only the same size as the catheter, there'd be a burn on the way out too, and that doesn't happen because it's so wide.
So this is connected to the patient prior to the ablation portion being started.
Exactly. The ablation wouldn't work if we didn't have this on the patient.
Okay.
So we need to have this, and this is very important so that we can actually get the energy from here to here and heat up the tissue that this is touching in the process. So one of the things that we learn with contact force is if we're not pushing enough, the lesions where we do the ablation doesn't actually last as long. They're not durable, to use an industry term. So we want our lesions to be durable so that they're permanent. We don't want someone coming back a month later, 2 months later with atrial fibrillation, which still happens, but now happens less because we know that 2 grams of force probably isn't enough. 5 grams is probably okay, up to 30, 40 grams may be okay. But we also know how much is too much. So the whole screen will flash red if we push too hard. So not only are we improving our success rates or our efficacy, we're also improving safety because we are limiting pushing too hard. And if we see it trending in the wrong direction, before we even push too hard, once you get used to this, you see the graph going in the wrong direction, you can back off before there's ever a problem. So lots of technology.
Amazing,
Incredible.
amazing. So incredible amount of tools, lots of technology. But I know that you don't do this procedure by yourself.
That's right.
You must have a pretty big staff on hand. Can you tell us a little bit about the roles of the people within the lab and how many people on average are in the room with you?
So sometimes other cardiologists or other people from other parts of the hospital will walk by and they'll kind of giggle a little bit because they wonder how many people it really takes to do a procedure, because there's a lot of people in this particular room. There's a lot of different roles because there's so much equipment and there's a patient on the table. So we have a lot of responsibility, and everyone for each procedure beforehand has a well-defined designated role that they have to stick to in order to make sure that the procedure goes safely and smoothly. And that process starts before I have to start the procedure, well before I start the procedure. So there's usually a nurse or a tech that goes to get the patient, and usually in each room there's both a nurse and there's an x-ray tech.
Okay.
And usually there's more than one nurse in the room, especially when we use conscious sedation. But there's a nurse that has to chart what's happening in the procedure, that has to get the medications we need whenever we're ready for those medications. And then if the anesthesiologist or if I need extra medication, they can get those medications for us. And then charting is very important, to have a log of the procedure and to know what we've done and when we did it. Because during the procedure, we may say, how long ago did I give heparin? Or when did I start the first ablation? We need to know those things so we can plan for what's next. And the nurse is responsible for that. Then there's Phil, who you've already met, who runs the 3D mapping system. And as I mentioned earlier, that's a critically important role. There's also someone who's running the recording system. So we talked about all the electrograms, all the internal electrical recordings. There's someone who's there and showing me what I need to see. They can update. I can say, what happened 10 minutes ago? Or what happened when we were pacing at 120 beats per minute? So that person can pull that up at any given time and tell me when we did that, and record all of the internal electrical information. So then obviously people need to take breaks. Someone needs to go out and make sure they've eaten during the day, or that they can go to the bathroom. So there's always extra people around so they can swap out during the procedure. I don't get to swap out, but I don't mind. But everyone else needs the option to do that. So there's a lot of extra folks in the room to make sure all of those things happen. And there's an anesthesiologist. And one of the beauties of having an anesthesiologist in the room is that means for every one of these, there's 2 doctors in the room. And even though we're not both anesthesiologists or both cardiologists, we both speak the same language, and we can talk to one another and work out issues as they come up. And it's just one extra safety mechanism to have an anesthesiologist in the room, and I really enjoy that. So that's
Great.
most of it.
Great. So I have a question. You talked a little bit about the radio frequency energy from the catheter that you showed us. Are there any other types of therapy for ablation out there today?
So there's some interesting therapies that have been tried and given up on. There's therapies that we've come back to where we thought we should give up on them. The main other option that we have for ablation is called cryoablation. So that's a colder technology, or cold technology. And the cryoablation for atrial fibrillation is usually applied via a balloon. So one of the differences with the way we do things with a radio frequency catheter versus a balloon is we refer to balloon catheters as one shot. And by that, I mean, Phil can rotate the map around for us. We rotate sort of to a PA view. So if we rotate the map and we look at one of these veins, let's look at a simple one here. Let's look at the right inferior pulmonary vein. It's got a nice circular opening. So if we had a balloon that we could push up into the opening of that, inflate the balloon so all the walls of the balloon touch the walls of that vein, we would then freeze, and wherever there was contact, we would actually apply ablation in the same way that we do with the ablation catheter. And the balloon, to some extent, is a one-size-fits-all, though there's multiple sizes of balloon, and you would then fit the right size of balloon to each one of these veins. And occasionally, when there's one large vein on this side, we may need to use the balloon in a different way to apply that energy to make that size balloon work. One of the things you'll note here, though, is one of the differences is with a radio frequency catheter. During this patient's repeat procedure, when they were having their second procedure, we realized that the veins weren't enough, and that this patient's atrial fibrillation was coming from beyond where the veins were. So instead of being limited to only being able to do the veins, we realized that the whole back wall of the heart, we call it the posterior wall, was potentially a culprit for that patient's atrial fibrillation. So the ablation catheter actually went all along the bottom here and up around the side so that all of this area was taken out of the picture and no longer contributing or potentially contributing to that patient's atrial fibrillation. So they're very different technologies in the way we do it, because the ablation catheter, every time I have to apply radiofrequency energy, I have to move it. So you can imagine the catheter is here, and we stay on for, let's say, 10 seconds, then I move it, and then we say, and then it will automatically take what's called a visi tag. Can you show the visi tags? Let's see. There they are. So we were actually able to see here.
Oh, so these are where you ablated.
That's right.
Okay.
So we can actually, these are objectively determined lesions. So in other words, I don't just say take a point there and let that represent where we were. We actually have criteria that we can set. So Phil can pull those up. We can pull up what are called the visi tag criteria, and we can say, all right, well, when I've been in this spot for 1 millimeter for 3 seconds and there's been enough force, we can check that off if we want, then it will actually then put a representation of an ablation there, and it will actually color it based on whatever criteria I want, whether it's time or anything else.
So is there any difference in the time of procedure for the RF ablation versus the cryotherapy that you mentioned?
You know, I think we can all talk about sort of the perfect world and how long it takes in a procedure that goes very smooth from start to finish, and there's obviously outliers as well. So typically the quickest this procedure would take would be around 1 hour and 20 minutes from start to finish, and that's at least for me, and that's about the same amount of time it would take for cryoablation. So they're about equivalent.
Great, great. So we've come to the end of the lab tour, and it has been great. Learned so much, and I know that our patients are really grateful to be able to have this experience. Can you talk a little bit about post-procedure and what a patient can expect once they're finished and they leave the lab and go to post-op?
Sure. So because we use anesthesia, typically we have an area called the PACU where anesthesia patients recover, the post-anesthesia care unit. And there's specialized nurses there that know how to take care of patients that are waking up from anesthesia and make sure they're comfortable and happy. Usually patients don't remember waking up in the room, even though they do generally wake up in the room. Their first recollection of waking up is in the PACU. And at that point, most patients are comfortable, a little bit groggy, and they meet with their family. And generally for me, about 4 hours after the procedure's done, if patients are comfortable and we're not concerned about the safety of it, we'll send patients home the same day. Many places elect to have their patients spend the night and go home the following morning, but it varies from center to center.
Okay, so presumably if they're feeling fine, they can resume a normal routine once they get home.
I would say the only limitation that I place on my patients is because there's the punctures where we have the catheters in the groin. I don't want my patients swimming for a week or so.
Okay.
They can shower right away, so there's not much in the way of limitations. Some people just feel tired for a day or two, a little draggy from having had anesthesia and having had a procedure, and just the exhaustion of having woken up really early to get to the hospital and spent the day there. So a couple days of feeling kind of tired and less than 100%. A lot of patients will have discomfort when they take a deep breath. The ablation technology heats through the full thickness of the heart and oftentimes will irritate the lining of the heart. And that we call pericarditis, and it usually manifests as discomfort when you take a deep breath. It can sometimes radiate to the shoulder, even the jaw, and it's a little scary when it happens. So we like to reassure patients that it's generally normal when they have that kind of discomfort. That's about it as far as discomfort goes. And patients usually resume a normal routine nearly immediately, taking walks the next day.
Okay. And you showed us a lot of incredible technology, and it sounds like the procedure itself has evolved into a very safe one. But even though it's safe, there's still potential risks. Could you talk to us a little bit about maybe what some of the risks might be?
I think it's very, very important to talk about risks. When we talk to patients in the office and before a procedure, we usually go over the risks with the patient. So the risks of this procedure start at the beginning, where we put the IV into the vein in the leg and start the sheath. There's always a risk of infection. So anytime we break the skin and open up a potential for a wound, that can result in infection. In addition to the risk of infection, because we're putting things in the vasculature into a vein, there's a risk of bleeding and there's a risk of damage to that vasculature that could result, even theoretically, and occasionally does result in the need for repair of that vasculature. That's rare, but it can occur. We're in the left atrium, and as soon as you cross over into the left atrium, there is always a risk of stroke, and we keep people on blood thinners. In our procedure, we don't interrupt blood thinners. So patients are on a blood thinner beforehand, they stay on their blood thinner even the day of the procedure without interruption. And we thin the blood even more than that during the procedure. But despite that, any clot that forms in the left atrium could result in a stroke. So with this procedure, there's always a risk of stroke. While low, it's important to know that. And there's the heart's a vital organ, and if a complication occurs in a vital organ, even something like death could occur. So
okay,
there's
so
always risk.
take it very seriously.
It's as minimally invasive as it is, and maybe as easy as the recovery is, we still have to keep in perspective we're doing a procedure on a patient in a beating heart with general anesthesia, and there's always risk.
Great, good to know about. Well, right now we're going to transition over to my favorite part. Not that the tour wasn't amazing,
That's right.
but I love it when we get to answer questions directly from our audience. And what we've been able to do is we've been able to gather some questions that have been coming to us over the last week in preparation for the time with you. So we've got a few questions from that. And then we're also going to be receiving some questions live from the Facebook feed. So if you have a question, go ahead and ask it. All right, so our first question is from Sue, and she wants to know, once you lose weight, will your AFib go away?
So there's some really amazing information about lifestyle modification and how lifestyle changes can cause AFib or contribute to it, and adjustment of your lifestyle can actually reduce the likelihood that you're going to have recurrent AFib. So we know that we can improve the success rate of ablation even by someone adhering to a healthy lifestyle, such as weight loss if they need to lose weight, diet, even if they don't need to lose weight, but as long as they're eating healthy, and exercise. So all those things that are a bit cliched for a cardiologist to tell you, turns out we have a lot of really good evidence that they impact not only things like coronary artery disease, but also rhythm problems like atrial fibrillation. So losing weight can be really important. We know that patients who are overweight are also more likely to have sleep apnea, and we know sleep apnea contributes significantly to atrial fibrillation. So for many reasons, I think weight is something very important to consider. And sometimes if patients don't want to do their part, it's not clear that we can fix their atrial fibrillation. So a lot of times it's a bit of a pact we make in the office when we talk about I'll do my part and try my way of fixing atrial fibrillation, but patients also do their part and do their best if they can to modify their lifestyle.
Okay, thank you. This next question comes from Anonymous, and I don't know why they're anonymous because it's a great question. So the question is, what does treating AFib early really mean?
So we typically don't consider atrial fibrillation to be atrial fibrillation until it's occurred more than once, because one time could just end up being one time. But once you've had more than a single episode of atrial fibrillation and it lasts for more than 30 seconds, you've gotten the label as having atrial fibrillation. Okay. And if you have symptoms from your atrial fibrillation and it's clearly been diagnosed as atrial fibrillation, you're right then and there potentially a candidate for ablation. Some people would elect to try a drug at that stage and see if a drug will suppress atrial fibrillation. Others are not willing to accept the risk because for some patients, depending on the other medications they're on or their background, those drugs may not be acceptable and it may not be reasonable to try one of those drugs. atrial fibrillation is a progressive disease, and atrial fibrillation in many cases becomes more frequent, and the episodes become longer. And also, as we get older and we rely more on the function of our atrium, it can actually become more symptomatic. So someone may have had 10 years of atrial fibrillation, and the first 8 years they could put up with it, and the last 2 years it's unbearable and they can't exercise or even take a light walk. So typically, the earlier we can start to address someone's atrial fibrillation, the better. And that begins with seeing someone who's a heart rhythm specialist early on in the process.
And for you, I know you do a lot of outreach to patients and also have an incredible relationship with your referrings. What about a patient coming into the emergency room? Like we have Linda asking, she has palpitations and she's repeatedly gone to the ER and she doesn't show up with AFib. How does she know the difference?
That's probably one of the greatest sources of frustration for our patients. The episodes are often transient. They know something's wrong and they go to their provider or the ER, and at that time they're in a normal rhythm. It's already passed. And we unfortunately can't figure out what has already passed, but we do have lots of tools to see what's going on if we look at their heart rhythm over an extended period of time. So there's rhythm monitors that we have patients wear. They look like patches, and they can watch someone's heart 24/7 for weeks on end. And then we get a report of everything that patient's heart did for weeks on end. And if the patient was able to say, at this time, on this date, I was feeling my palpitations, and we look back and we see they were in a perfectly normal rhythm, we know that those symptoms may not be from their heart. But the other side of that is we may find that that patient had 2 minutes of very symptomatic atrial fibrillation. And 2 minutes of your heart going 200 beats per minute can be awful, and it's hard to get someone to believe you if they don't have a picture of it. So that's a great way to do it. And even further, we have what are called implantable loop recorders or patient-activated event monitors that implant under the skin. And they're more or less injectable devices that are very small that can watch the heart 24/7 for currently up to 3 years, and soon we'll have one that'll last up to 5 years. It takes 2 to 3 minutes to put one of those in, and it talks to a system remotely and is actually able to tell us what happens to that patient's heart every day, all day for up to 5 years. So there's lots of ways to make it so we don't have to keep going to the ER every time we have a palpitation.
That is so great to have all those options and give the patients back some of that control. Yeah. Okay, Bobby asks, how old is too old for an ablation?
When I was in my training, there were patients that were in their 80s who we absolutely say no, that atrial fibrillation ablation isn't an option. And because we were afraid that we would make them worse, that they were more frail. Since then, we've got good studies in octogenarians, patients that are well into their 80s, and we know that the safety data is just as good as for patients that are not in their 80s, and that the outcomes data is just as good. So patients will actually do just as well with an ablation if they're in their 80s. So now, all the way up to under 90, patients may be reasonable candidates for an ablation, and we know that it's just as safe. And that's looking at the bigger picture. There are, of course, patients that are frail and in their 80s that are poor candidates. So not everyone in their 80s is necessarily a candidate, but we know that in a well-selected patient population, age is not the critical deciding factor whether someone's a candidate.
Okay, so Bobby should still pursue meeting with probably an electrophysiologist or going back to his cardiologist.
Yeah, that's right. And I think the other side of that question, which is important in places where you have a lot of active patients, we see a lot of atrial fibrillation in endurance athletes and in young patients as well. So we'll have endurance athletes, cross-country runners that are in their 20s or cyclists, and they'll have atrial fibrillation. And even though sometimes it's more difficult to fix their atrial fibrillation, they're generally really great candidates for a cure. So it goes both ways.
Right, right. Okay, next question is from Diane. Can a patient with mitral valve replacement get an ablation?
Absolutely. Absolutely.
Okay.
So we see that all the time. We really like to work in conjunction with our surgeons. A lot of surgeons have access to tools that are very powerful when they're actually looking at the heart. So they can do ablation during the valve surgery, and they can even get rid of the left atrial appendage where clots form during the valve surgery. And they can do most of the work for us. And then as an electrophysiologist, I can come in and find the couple of areas that may have healed or a couple of areas that need to be addressed with a catheter and think of it as a hybrid procedure. But even if a surgeon doesn't do that, we call that procedure a maze procedure. So if a surgeon doesn't do the maze procedure as part of the valve replacement, we can actually go in and do start to finish the ablation, even with having had a valve replacement.
Great, great. So Kathy asks, what do you do when you repeatedly tell the doctor that you have palpitations and they keep telling you that they're fine?
Well, the doctor's right in the sense that they're fine when they come in, but as I said, even physicians that don't take care of heart rhythm problems all the time, when you just look at a snapshot where a Holter monitor, a 24-hour monitor shows 30 seconds, 45 seconds at 200 beats per minute, that can be extremely symptomatic, even though it's very, very short in duration. So typically we recommend that patients seek out a heart rhythm specialist and see if they can get access to one of those other ways of seeing what the heart's up to when they're not in their doctor's office.
Okay.
So that when they're having the symptoms, we know what the heart's doing. But I will tell you that some patients do feel palpitations, and when they're on the monitor, their heart is actually in a normal rhythm, and what they're calling palpitations are symptoms from something else sometimes.
Oh, okay.
So we need to look at it carefully, and obviously we want to give patients the benefit of the doubt and make sure we get a picture of what their heart's doing when they have those symptoms.
So by a process of elimination.
Yes.
I see. Okay. So Diane asks, if your heart is in AFib 15% of the time, is that a lot? And part two to the question is, are antiarrhythmic drugs a good option to try before an ablation?
So 15% of the time can mean a lot of things. So if I put a 14-day monitor on someone and they spend 24 hours of that 14-day monitor in atrial fibrillation, that's one way of meeting that 15%. But another way would be to have hours of it multiple times a day. So some patients may find that one day every 2 weeks isn't a lot, but a couple of hours every day that adds up to 15% is a lot. So it really depends on what that 15% is made up of and what the rhythm's like during that 15%, because sometimes 15% is very fast and symptomatic, or a couple hours here and there, the heart rate's very fast. Even though you may be in atrial fibrillation for all of that 15%, some of that time in atrial fibrillation, the heart may not be going fast and it may be minimally symptomatic, or it may be always when a patient's asleep so they don't realize it. In terms of stroke risk, 15% is considerable, and if someone has the risk factors for having a stroke, 15% is more than enough to justify, in most patients, being on a blood thinner. So.
Okay. Judy asks, if one has AFib and it's totally left untreated, drugs or ablation, what happens? What does it cause?
If you look at AFib patients as a whole, the risk of stroke from atrial fibrillation is 5 times more than someone without atrial fibrillation. So untreated atrial fibrillation, certainly if you have stroke risk factors, is a really big deal. Even if you don't have stroke risk factors, the atrial fibrillation that drives the heart to an elevated rate, if it's untreated, can lead to heart failure, severe heart failure. And that's usually, if we catch it in time, reversible, but it can lead to irreversible problems with the way the heart functions. It's very important to address atrial fibrillation. Not everyone has to be on medications for their atrial fibrillation. The vast majority of patients do have to be on some sort of medication to make it so that their atrial fibrillation is not going to cause long-term problems.
Okay. So definitely take it very seriously and make sure that you're seeking treatment. Don't let it go.
I think that's the best way to look at it.
Okay. So Tammy asks, I have AFib, medications aren't working. What's my next step?
So I think that we can answer the second part of the last patient's question and answer that question. So rhythm controlling drugs are reasonable to take. So the last patient's question was whether or not it's reasonable to take rhythm controlling medications before ablation. And some of those rhythm controlling medications will make atrial fibrillation stop altogether and never come back again as long as the patient takes that medication. Generally, though, they don't fix the root of the problem. So when the patient stops the rhythm controlling medication, the atrial fibrillation will unfortunately come right back. The rhythm controlling medications may not cause any symptoms or side effects, so they may be very tolerable. But for others, it makes it so that the EKG is pretty and they no longer have atrial fibrillation on their EKG, but they've traded the symptoms from atrial fibrillation for the symptoms that come with the side effects of taking a medication.
Oh, okay.
So if the medications aren't working, then there are a lot of different medications that can be tried, but we don't always just want to keep trying additional different medications. Sometimes we actually have to give up on medications as an option and realize that we either have to accept atrial fibrillation for being there all the time without medications or go to ablation as an option. So we don't always have to leave ablation as the last ditch effort to salvage someone's atrial fibrillation after they failed multiple drugs. We may go to it early on, but certainly we don't want to just keep changing from one rhythm controlling drug to another. Generally, if one rhythm controlling drug fails, we now realize it's unlikely that another rhythm controlling drug will work. And since we're talking about it, there's a distinction between the two ways we approach atrial fibrillation, whether we try and fix the heart rate when someone's in AFib or we fix the heart rhythm. So some of the drugs are called rate controlling drugs, and their job isn't to right the ship and push the patient's rhythm back to normal rhythm. All they're designed to do is make it so there's less symptoms, and when they're in AFib, the heart rate isn't too fast. Those are rate controlling drugs. Rhythm controlling drugs are the ones we focused on mostly today, and those are the drugs that are really designed to fix the rhythm and help it stay in normal rhythm. And they don't cure atrial fibrillation. The idea is that rhythm controlling drugs make the episodes of atrial fibrillation fewer and further between. Typically, the bar that we set for ablation is a little bit different. So we look for rhythm controlling drugs to make it so you have fewer and further between episodes that are less symptomatic, whereas ablation, we set the bar at, we're trying to cure atrial fibrillation so that you don't need to take a medication and so that it never comes back. Now, we may not achieve that. That's the bar we set. We may have to settle for fewer and further between as the outcome of ablation, and that may be reasonable for some patients. So if you're having AFib for an hour a day and you have an ablation and then you're having it for an hour once a month, that might be a good endpoint. And maybe we didn't cure it, but that patient might be actually happy with that outcome and not having to take a rhythm controlling medication. And other patients, the rhythm controlling drug may not be working, so we go for an ablation. And after the ablation, there might be a synergistic effect for that drug that used to not work. It actually
it might work again.
Yeah.
Oh, okay.
So it's not unreasonable to go back to those drugs after an ablation. And it may be that the two are required together in order to make someone's atrial fibrillation go away and stay away.
So it sounds like it is going to be different for everyone.
Yes. There's no recipe book.
No recipe book. Okay. All right. Marion asks, what is the percent of great results from ablation?
So just like it's different for everyone, the ablation success rates vary to some extent based on patients' risk factors, what their heart looks like and how it's functioning, and how long they've been in atrial fibrillation for. So we'll start with best case scenario. If a patient has an otherwise healthy heart and they don't have a lot of other medical problems and their atrial fibrillation comes and goes. So they're not in atrial fibrillation all the time. Their atrial fibrillation is what we call paroxysmal. So at each episode of atrial fibrillation to qualify as paroxysmal has to be under 7 days in duration. So if the episodes of atrial fibrillation are always or almost always on their own under 7 days in duration, and we don't have to shock the heart back to normal rhythm, we call that paroxysmal. And paroxysmal atrial fibrillation ablation success rates with the Smart Touch catheter that we were talking about earlier have been shown to be in the upper 80% range because we can apply those good lesions and make sure every burn counts, and the success rates are really excellent. And the ablation success rates for patients that have sicker hearts may be as low as in the 50% range. So there's a wide range, and that's why you don't want to ask your friend what they were told their success rates were or if it worked for them. It requires, I think, a really thoughtful conversation with the electrophysiologist about what their chances of success are and what it's going to take to get there.
Okay, good advice. Very good advice. So Linda has had 3 ablations. She's 68 and she has cardiomyopathy. What can she expect if her 4th ablation doesn't work?
So the fact is, and this is a great question because we have to highlight it. We talked about risks of ablation. We have to talk about the fact that in that nice sounding 80+% success rate for paroxysmal atrial fibrillation, there's 10-15% of patients in whom this doesn't work. And that may be after trying multiple ablations. So I think first of all, let's talk about multiple ablations and what does that mean and why does that happen? So if we go back to our map here and we look at this picture, Phil, can you rotate the map to the right a little bit and rotate up a bit? So let's say we pick one of these lesions right there. If that spot I was careful in because the esophagus is there. Phil, can you pull the esophagus up for us? This is really cool. You guys should check this out. So we drew a picture of the esophagus.
Oh, right here.
That's right.
Okay.
So if you look on this screen, rotate right a little bit, Phil. This is where the esophagus is in that patient. And we don't want to burn anywhere near that esophagus. And if we have to, we want to be very gentle because we don't want to damage the esophagus. And will you put the fan on for 1 second too, just so we can see how we got there? So there's what the ultrasound looks like. So that's a picture of ultrasound and the beam of the ultrasound going through the heart, and it's going through the esophagus behind the heart. So we actually can see where the esophagus is in the heart and what it looks like behind it. So we can turn it off for a second. If that one burn, because I was being careful, doesn't work, electricity is going to be able to easily get into that vein and out of that vein. So if that patient's atrial fibrillation is coming from over here and that electrical wavefront gets out and causes a problem, we may need to go in and fix that one spot. So we'll go ahead and we'll burn that one spot, and that seals off the vein, and that repeat ablation is much simpler than the first ablation, but actually can make a dramatic difference. So it was because we were careful, we were erring on the side of safety, that they may need a repeat ablation, and that repeat ablation may be simple and result in success. But the alternative to that is that patient's atrial fibrillation wasn't coming from where we expected it to come from, and we just don't have the technology yet, perhaps, to figure out where that patient's atrial fibrillation was coming from, and it just may not work. In which case, we could try a drug that didn't work before and see if that fixes that patient's atrial fibrillation, or we may just have to accept atrial fibrillation as something that's going to continue to happen and come up with alternative strategies to improve symptoms and deal with atrial fibrillation.
Okay, fair enough. Jane asks, I have 1 AFib episode per year and for the last 2 years. Should she be worried?
Worried enough to make sure she talks to her cardiologist or to an electrophysiologist about what that means for her. It depends on whether she has a risk of stroke from that atrial fibrillation and what the duration of that episode is and whether or not that episode could be damaging to the heart.
Okay. So I have 2 questions from Dottie. One is, how long after my ablation will my symptoms go away? And we'll start with that one.
Okay.
So I don't forget the second question like I did before.
So the ablation sometimes kicks up the dust, if you will. So when we do an ablation, we bother the heart and there's some irritation. Like with any surgery, when you perform the surgery, there's an inflammatory effect. And inflammation, it turns out, can cause atrial fibrillation. So even if the ablation fixes that particular patient's cause of atrial fibrillation, the resulting inflammation can actually cause recurrences of atrial fibrillation until the inflammation settles down. Electrophysiologists refer to that as the blanking period, and that typically lasts for 90 days. So when someone has a recurrence of atrial fibrillation in the first 90 days, we don't worry too much. Now, it may mean that the success rate for that patient is a little lower than someone who had no recurrences. That patient's atrial fibrillation may go away and never come back again. So we see that inflammatory effect lasting for sometimes weeks and sometimes months, and there may be multiple episodes of atrial fibrillation, and we all get disappointed. We can't help but do that during that period of time. But sometimes that atrial fibrillation will go away after the end of that 3 months. So it really, again, it depends on the individual patient when those symptoms are going to go away, but it can last that long. Some patients, their atrial fibrillation may be triggered by alcohol, let's say. We know that drinking alcohol is a common cause of atrial fibrillation. And no matter how much I fix on my end, if we don't have that pact that we talked about earlier and patients don't do their end, it's possible that we can't fix the AFib. So if someone's drinking a bottle of wine a night or multiple glasses of wine a night, and they know that for them that's their trigger, until they change their trigger, they may continue to have atrial fibrillation. So again, we have to individualize the answer to that question.
Okay. Hopefully mine's never wine.
Yeah.
Okay, second question from Dottie is, will I be in pain after my ablation?
For most patients, it's not normal to have pain after the ablation. Patients' thresholds for pain are different. So sometimes the pain in the area where we do the procedure in the groin can be significant. And occasionally it is very uncomfortable, in which case we would say, spend the night in the hospital, make sure you have adequate pain control. Make sure if you do have pain that you bring it to your doctor's attention right away. You don't want to wait and see if it goes away. If you don't think it's normal, the first thing you need to do is call your cardiologist or the electrophysiologist that did the procedure and make sure they know about it and that they feel that it's a normal, that it's normal. And if not, then it may need to be addressed.
Okay.
But it's not normal to have pain afterwards.
Okay, so keep an eye on it.
Keep an eye on it, yes.
Right. Okay, last question from our audience today.
Okay.
John asks, is using a mobile EKG such as Cardia helpful for my cardiologist? I think we covered some of this.
We did. If you send every one of those Cardia EKGs to your cardiologist every 2 or 3 minutes, it's not helpful. But if you're recording what's going on with your heart and you work together to get that snapshot of what the heart's doing to your cardiologist's attention to make a diagnosis, that's helpful. So if we know someone has atrial fibrillation 10 times a day in general, we don't need a recording of all 10 of those episodes every day. But if we don't know that a patient has atrial fibrillation and they get a monitor like Cardia or an Apple Watch, the new one, and they record what their heart's doing and bring that into their doctor and they work together to come up with a diagnosis, that's really helpful. Or if we give a patient a medication, let's say we give a patient a drug that slows their heart rate down, and we assume that it's doing its job, and they catch a picture of their heart going very fast when they're in AFib, we know we need to change that medication regimen as a result of it. So I think it's adjunctive. It can be very helpful to have a patient's monitor their own heart in moderation.
Okay. So more data, but good data.
That's right.
Okay. Any parting words of advice for our patient population out there?
I'd say the most important thing I do in my practice is find the patients that have atrial fibrillation that are at risk for stroke and make sure they're protected from that risk of stroke, and we reduce it. So if you've been put on blood thinners, taking those blood thinners is the most important thing you've ever been told because strokes are usually irreversible. And seek help early. Make sure you have a good rapport with your physician and that you're able to tell them what's going on, that you're being listened to, and that if you have atrial fibrillation, even though it's common, that you don't just ignore it, that you bring it to the attention of your cardiologist see an electrophysiologist and discuss it with them and come up with a plan that's right for you.
Great advice. Thank you so much for your time today. It was really beneficial to me, and I know to all of our patients. It sounds like you have a thriving practice, and thanks for letting us have a window into what you do. Sounds like 7 days a week.
Yeah, that's right. It was a blast.
Yes.
A pleasure. Thank you.
And I also want to take a chance to thank Phil, the cartomapper.
Hey, Phil.
Appreciate it. And also a real pleasure to spend the month of September traveling around to all of the different facilities, meeting with the physicians. Thank you so much for joining us for the Facebook Live series for AFib Awareness Month. More to come from us, but if you'd like to keep track of us, go to getsmartaboutafib.com and you can find tons of information there. But with that, we'll leave you and have a great rest of the week. Thanks.
Bye-bye.